To discuss what can be done to fight opioid addiction, we welcome in our studio Kate Tulenko. She is the CEO of Corvus Health. From Los Angeles, Ryan Hampton is a former opioid addict and activist and author of the book American Fix: Inside the Opioid Addiction Crisis and How to End It. Also from the West Coast, Keith Humphreys is a professor at the Department of Psychiatry and Behavioral Sciences at Stanford University. And Bradley Stein is the Senior Physician Policy Researcher at the RAND Corporation. He joins us from Pittsburgh. Thanks to all of you for joining us. Ryan Hampton, let me start with you. I've been reading about your story, and what a story it is. You worked at the White House. You worked very closely with President Bill Clinton, but a few years later, you were homeless. You were desperate for money because of this opioid addiction. Tell us briefly, how did you get from being a staffer at the White House to being this opioid addict?
Well, thank you for having me on. I mean, first and foremost, we just listened to all these numbers. The Washington Post has done some phenomenal reporting. You know, the number that has come out in the last 2 weeks has been 76 billion pills, I think over a 6-year period, which is quite an astonishing number. But I could have, told you years ago that this was a problem. I mean, now we have data to back it up. But as you said, I was an up-and-coming political staffer. I worked in President Clinton's administration, 1999 to 2001. I left the administration shortly after the president left office and stayed in Washington, D.C. to pursue a career in politics. And in 2003, I was on a hiking trip with my roommate, fell and injured my ankle, injured my knee, ended up in the care of an urgent care physician, where I was prescribed a very high-grade opioid called hydromorphone, also known as Dilaudid. But the real nexus of my story was shortly after that injury, I moved back down to South Florida, where I'm from, specifically Broward County, Florida. And if you now know anything about the opioid crisis, which most of America and the world knows, before there was this big opioid crisis, we had a pill mill crisis, where these pharmaceutical companies that we're now hearing about through the Washington Post's great reporting on the opioid files, were sending, millions and millions and millions of pills to that county, specifically in a very short period of time. I got caught up in that pill mill crisis with unscrupulous doctors very quickly. Right. And it developed into full-blown addiction. And when I was eventually cut off from the medication, which I was a few years later because of a new policy they instituted in the state, I went to heroin. And this is not, outside of working in the White House, this is not a very uncommon story for many people who are now survivors of opioid addiction, and many people like friends of mine, over 24 who have died at the hands of opioid addiction.
Keith Humphreys, listening to Ryan's story there, how did this become such a big problem, opioid addiction? It's widespread, not only in the United States, but also around the world now.
Well, as Ryan said, the key factor is a massive increase in supply. And what you saw in the United States was regulators backed off, doctors were too trusting, and the companies pushed their products extremely aggressively and managed to increase prescribing in the U.S. by 400%. To the point that we were putting out of the healthcare system about 250 million prescriptions a year, which is more than one prescription per adult in the entire country. This has also happened in Canada, has had a big increase in prescribing and has an opioid epidemic. And we're now seeing it, as your setup piece mentioned, in other countries as well. So whenever a drug becomes extremely available, it's just a law of nature that more people will try it, and some of them will be harmed by it, including becoming addicted or overdosing or both.
Yeah, that is one side of that, Keith. But we heard in our report there, the suppliers and manufacturers of these drugs say, we weren't pushing any drugs, we were just meeting demand.
I'm sure they would say that. We got to look at the situation, and they're facing $1 billion of damages, which in my opinion they deserve to pay. I mean, if you send, as happened, representatives out to doctors and say, This is a new medication. It is not addictive. It will take care of pain. The compassionate thing is to prescribe more and more of this. If it stops working, go ahead and increase the dose. There is no risk. I mean, Purdue Pharma actually admitted to doing all these things in a federal lawsuit publicly in 2007. So it's not as if customers just came in and asked for this freely. They were told it was safer. Doctors told it was safer, and it was a lie.
Can I just jump in real quick, because I think it's important to also say, to add on to what Keith was just saying, we've also learned the systematic extent that these manufacturers and distributors, Purdue Pharma particularly, lied to the American public. I mean, and they knew, now looking at the unredacted lawsuits out of Massachusetts,
right.
And some of this information that came out of the opioid files, they knew people like me were getting hooked. And they pushed more and more and more. This was a very well-coordinated, systematic attack on American families that involved doctors, pharmacies, and all the way at the top, I believe, the federal government.
Talking about the federal government, Bradley, this is President Trump talking about the opioid crisis. He's talking about it first in 2017 and then in 2018. We got two separate sound bites. Let's listen.
As Americans, we cannot allow this to continue. It is time to liberate our communities from this scourge of drug addiction. Never been this way. We can be the generation that ends the opioid epidemic. We can do it. Together, we are going to end the scourge of drug addiction in America. We are going to end it, or we are going to at least make an extremely big dent in this terrible, terrible problem.
So, Bradley, there you hear it. There is a recognition on the part of the federal government that this is a major health issue. But what is the government doing to fight it?
I think the government has taken a number of steps in terms of passing legislation to increase funding to states and to programs to address the problem. There are guidelines going out to doctors. But I think what we need to recognize is, you heard in the lead, and as Ryan and Keith have referred to, this is a massive problem right now. And I really think one of the issues that we need to face is we need a level of investment that is commensurate with the level of the problem, and we don't yet have that. So I do think we need an investment that's going to address all aspects of this problem. Certainly, we need to make sure that physicians aren't prescribing more opioids than people need, and really are thoughtful in the prescribing. But we also need to recognize that our treatment system and the availability of treatment who are struggling with addiction with opioids is insufficient. People can't get into the treatment they need. Many people get treatment but aren't getting the most effective treatments. We really need to strive to make those more available. We need to do things to reduce the harms of people who are struggling with these problems. Naloxone, which can prevent people from overdosing, and other steps like that. So I think there's a broad effort. So while the federal government has taken some steps in the right direction, I really think that far more needs to be done.
Yeah, Bradley, when you talk about investment, where would the money, or how would the money be spent? I mean, you talked about treatment there, but what about preventing people from starting in the first place and becoming addicts?
I think we absolutely need to stop people from using and misusing opioid pills. I also think, though, we need to recognize that at the same time, in recent years, you've seen a spike in terms of heroin and fentanyl. So while we're paying a lot of attention to what doctors are prescribing and the opioid pills that we've talked about, we also need to be paying attention to these other ways that people are getting using opioids. So I don't think there's a one-size-fits-all. I think we need to really be addressing the crisis on all of these fronts in a way that is sufficient to address the challenge that we have.
All right, Kate, let's bring, I'll get to you in a moment, Ryan. I just want to bring Kate into the conversation. Kate, this is also a hot-button political issue, and we are now firmly in election season. The campaigns have started in earnest. It's been compared in many respects to the debate over guns in this country. And this is what Bernie Sanders, one of the leading Democratic candidates, had to say. Let's watch this.
And what we need to do right now is to hold those gun manufacturers responsible if they are selling guns far more into a community than they should. And by the way, exactly the same thing with opioid manufacturers who are selling zillions of pills to communities that cannot accommodate.
So he's talking about accountability there, and
Yes.
have we seen any accountability thus far?
I think we're starting to see accountability be driven through the legal system. There was a settlement a couple of years ago with Purdue, but also right now in Ohio, 48 states and literally thousands of cities, counties, and tribes are suing Purdue and other manufacturers. And so there's a framework right now for how they might compensate these political jurisdictions. So that's one way to drive accountability. We have also seen some executives go to jail for racketeering, for lying about the threat of the opioids. But also, I think another form of accountability is to help everyone design better care management plans. And the U.S. government in 2016 did release a national chronic pain management plan. And so that's to help health workers, doctors, nurses work with patients to design better care plans. So people like Ryan are never prescribed opiates in the first place. That instead they get physical therapy, they get behavioral change, like meditation, exercise, hot or cold packs. They get anticonvulsants, antisteroidals. There are a number of different types of pain medications that can be used.
Because one of the things I read, and this is in no way defending what's going on, is that doctors find it very difficult to measure pain.
Yes. Yes, there's no objective measurement. In some cases, you will see an increase in heart rate with pain, but otherwise, there's no objective measurement. And some people blame hospital regulators for making pain be a sort of a quality metric, in that physicians felt obliged to overprescribe pain medication because they didn't want to be dinged on quality measures. And also, many physicians are compensated according to patient satisfaction. And so someone seeking drugs and being turned away can really affect a physician's score.
Ryan, go ahead.
Now, I was going to say, listening to I was in the room with President Trump when he made that latter statement that you played in the package, and listening to Senator Sanders and the other presidential candidates, the rhetoric, not just of political campaigns, but the rhetoric coming from the White House and the federal government does not match the action needed. You talk about sizable investments to actually combat this crisis. Well, we're looking down the barrel of probably, at least in the United States, a minimum of $10 billion per year that needs to be across the entire spectrum, from prevention, treatment, recovery, harm reduction. I mean, that's a real number. We would be lucky at this point to say that we've received maybe $6, possibly $7 billion in federal investment since the last 2 years of the Obama administration moving into now. So there's been a trickled response, I think, coming from the federal government. I would also just add, we are in danger, I think, of a massive relapse for the opioid crisis, but not just the opioid crisis, the addiction crisis in general here in the United States and worldwide. Part of the problem is that there is such a hyper focus on opioids, which is important. It is a huge part of the problem. But underneath that, we have a booming meth crisis, amphetamine crisis that is starting to rear its ugly head. And unless we start providing solutions for recovery-oriented systems of care from any substance, we're going to keep dealing with another drug crisis every 5 to 6 years in this country. The healthcare system at the heart of it is just broken and is not prepared to deal with people who are struggling from any substance.
Right. Keith, what do you make of that? Are we going to see a relapse? I mean, is this going to get worse?
It could conceivably get worse. I mean, particularly if you take a global viewpoint, companies are very active in a lot of nations that have weaker regulatory standards than rich nations. They can't resist them as well. And there's also plenty of other addictions we're not addressing that well. I mean, alcohol is responsible for about 5% of all mortality on this planet, and is, not given sufficient attention when we talk about addiction. Every opioid crisis we've had in the United States has been followed by a stimulant crisis, cocaine or methamphetamine, and we're seeing that now. There are plenty of states, Oregon is an example I happen to know, where the #1 killer is now methamphetamine, not opioids. So Ryan is completely right. It's about addiction. It happens to be opioids is the thing we're focusing on, but we need generic responses so that anybody can walk into their doctor, no matter what substance they happen to be addicted to, legal or illegal, a stimulant, an opioid, alcohol, or whatever, and say, I need help, and get it.
Go ahead.
So to build on that global point, there's a UN agency called the International Narcotic Control Board that can be strengthened. They have two purposes. One is to improve access to appropriately prescribed opioids, particularly people with cancer pain and with terminal pain or people with acute pain, but also to prevent addiction or to prevent illegal use of opiates. So that can be strengthened. And there's this concern, as was mentioned, that Big Pharma is taking the tobacco playbook, and that when the industry was sort of shut down in the U.S., they went elsewhere. Well, we've seen declines of about 30% in opioid prescriptions in the U.S., and so the companies are now being much more aggressive in developing countries.
Bradley, we hear a lot about the abuse of these drugs and the addiction that it causes, but what kinds of regulatory mechanisms are there, not just at the federal level, but at state level as well, to prevent this kind of thing happening? I mean, are they still in place?
Well, I think there are a variety of regulatory mechanisms, but I want to pick up on something that Keith and Ryan had talked about, is the importance of treatment and making sure that we're not just focused on opioids, but there are many different types of drugs that you see people struggling with. And I think one of the challenges we have in our health system is oftentimes we focus on this as being an acute issue that we are going to address once and then step aside from. But these are chronic challenges that many of these individuals face. And I think really thinking about how do we restructure our healthcare system to address what for many of these individuals is going to be sort of a chronic episodic challenge that they may face for long periods of their life in struggling with that addiction.
Kate, how would one restructure healthcare? Because in many instances, when we look at what's happening, say, in the legal realm, you get many big pharma companies, they're out-of-court settlements, they pay, I mean,
and then nothing changes.
Nothing changes, yeah.
The opioid epidemic definitely exploited the cracks in the U.S. healthcare system. For example, a patient could go to one ER and get a prescription, then go to another ER and get a prescription the same day. So we're doing a better job now of tracking prescriptions and identifying people who are doing that type of doctor shopping. So that type of information and data sharing is an important thing. Also, the other things I mentioned, better training for nurses and physicians so they know how to do care plans, but also educating patients so they're not demanding and expecting opioids. It's very difficult when you're facing a person who's writhing around in the bed and in pain, and how to explain to them that opioids are not really the best choice for them.
Yeah, the thing is, a person, sorry, someone
No, I just wanted to add on to that, because I do want to add the PDMP, the Physician Drug Monitoring Database, that I got caught up in Florida, and I still see it today. I mean, being able to prevent someone from misusing or being overprescribed opioids is one thing, but once you identify that patient, much like I was, you have to have somewhere to send them to get them help, because what we're seeing is people who are getting cut off from opioids, and this is happening all across the United States, and they're not just stopping their use or misuse, they're switching to heroin or fentanyl, and that's why we're seeing a spike in fentanyl use and fentanyl overdoses. I mean, so people don't just stop because there's higher regulation in terms of stopping the prescription. We have to have somewhere to send them to get them help, and that infrastructure is almost non-existent in this country, which is why the treatment gap is so high. Now, 9 out of 10 people will not get help for their addiction of any kind because it's just out of reach for them and not in place.
Yeah, Kate, what I was going to ask you was, this addiction might start with good intentions, as Ryan told us. He had an accident. He hurt his ankle. He was given opioids and then crossed the line somewhere into becoming an addict. How does one check that? How does one, stop and say, well, look, we've got a problem here?
Part of it really is the switching to other forms of pain control, and educating the public. I think also we can do a lot more with the non-drug therapies as well, because people will always have pain. As someone mentioned, it's not going to go away. It's going to be a continued problem that we have to face.
All right, Keith, I was reading a piece that you wrote in Foreign Affairs in which you said that Big Pharma is facing a backlash right here in the United States, in Canada as well. And drug companies are now turning their attention to other parts of the world, like Asia and Europe, and repeating the tactics there. But as you point out, the world has remained largely complacent. Why?
At least part of it is when I discover when I go abroad and talk about this, is people think that's something American. The opioid epidemic could only happen in your nation, the way you structure healthcare or the way you have inequality and so on. And it's always a shock to them to say, well, Canada has universal health care, a totally different financing mechanism, far less inequality, and an opioid epidemic. And you know, it's a shock to them to lose that reassuring idea that it could only happen in America. But in fact, you know, it can happen anywhere. I mean, there's, you know, the appeal of drugs that, you know, is hardwired into us is not American, it's human. And any environment that gets saturated with any drug, no matter what it is. You think of cigarettes back in the 50s were everywhere. More people are going to use them. So the world should wake up. It can happen anywhere, including where you live.
Ryan, of course, one strategy is to prevent more people from becoming addicted. But what about those who are already addicted?
Sure. I mean, what we need is a recovery infrastructure. So, I mean, prevention and treatment are only two parts of the process. I mean, you really need harm reduction, prevention, treatment, and recovery. So for me, you know, I had been through treatment over a half a dozen times. We now know, you know, the U.S. Surgeon General's report of 2016 on alcohol, drugs, and health stated that if we can get someone past the 5th year of sustained recovery, that they have an 85% chance at maintaining that recovery for the rest of their life. We do not have the supports and infrastructure in place to help people like that. What does that look like, though? There's a misconception, I believe, that people say, let's get as many people treatment as possible. Yes, treatment works, treatment is important, but folks need a stable, place to live, housing, recovery housing when they get out. They need peer recovery support services. They need health care. They need help with finding a job and employment, things that will help lead them to a more purposeful life that will allow them to kind of, you know, re-engineer their social integration into life, which has a better chance at sustained recovery. Those types of services and systems are almost non-existent in this country. But there are solutions. You know, Senator Warren has the CARE Act here in the United States, which would fund services just like that. But it's very hard to get policymakers to reshift their focus into, you know, long-term maintained recovery for people who do survive, rather than just focusing on that acute crisis phase, which is where a lot of the money seems to go.
Bradley, in that search for solutions, as we heard earlier on, many are comparing this fight against opioids with the fight that was staged against tobacco companies. I mean, is that a good comparison? Is that a good strategy? Is there a parallel there?
I think we need to learn from some of the mistakes we made in the issues with tobacco. Certainly one of the places where I think we critically need to learn is when we look at the tobacco settlement dollars and how those dollars were spent. Very little of it actually went to preventing tobacco, and I think you're hearing all of us basically say we need to take any dollars that do come from opioid settlements and invest it in treatment, invest it in prevention, invest it in harm reduction, invest it in many of these other areas that are being affected by the opioid crisis. And we're also oftentimes focusing on the individual, and while that's critical, I think we also need to recognize that there's a ripple effect of the opioid crisis that's going to be with us for years. There are many communities where you have tremendous numbers of children being removed from their families and ending up in foster care or kinship care or someone else taking care of them because their parents at that time aren't able to. You have many individuals who you've heard people tonight talk about moving from pills to heroin. Well, along with that comes risks for hepatitis C and HIV. And for the individuals who contract those diseases, we need to make sure the healthcare system also has the investments to be able to take care of those illnesses over time and care for those individuals who've contracted those illnesses because of the opioid crisis. So I think what we certainly need to do is learn from the tobacco settlement and make sure that the dollars that do come from any settlements really are invested back in our society in ways that help to address the crisis.
Okay. Go ahead, very quickly, Ryan.
That's already being a problem, actually. Yeah. We could see what happened in Oklahoma. Majority of that money went to go build a new university research center. So we're at a huge risk of those funds being misspent.
We're going to have to end it there. We've run out of time. Thanks to all of you for being with us. That's it for this edition of The Heat. I'm Anand Naidu in Washington, D.C. Thanks for watching.